Thank you, this youth wing, for having me here, and thank you, Pooja, for arranging the visit of Neil Bressler, because it was very illuminating. Although I've heard him 7, 8 times, but it's always you always become wiser. I'll talk something about PDR because DME is always controversial. PDR I thought is not controversial, and I also thank Himanshu and Amar and everybody for initiating. And I never knew that this is chapter 5. I still want to see what all you have done in 4 chapters. So, till today, I still think that in PDR, whatever AB study may still say, laser is still the mainstay of management. And intravitreal injections, you see, you rarely get those non resolving vitreous hemorrhages now, what Neil was talking about. You rarely get those vitreous hemorrhages. And I agree, if patient presents vitreous hemorrhage, and if you are very confident of your ultrasound, you may do that. Because ultrasound is a subjective kind of test, is an observer based test. You can never be sure of those findings. So we laser, you see, not only HRC, we laser without HRC also, and sometimes very severe NPDR also. So PRP has been the treatment for not only PDR for decades and decades. It's not only now, since the DRS study demonstrated nearly 4 decades back. The confusion started once this anti-VEGF came, and this one of the DRCS study which compared PRP with the Rani Mizubab, and what they cleverly said was it is non-inferior to PRP. But what about situation like this? You see, this patient has very good vision. You see the huge number of massive fronts and a lot of non-perfusion. So I'm very fond of giving these biosimilars here. So I injected ranimizumab, this front shrunk, and then I did laser. So laser to me is the main stage for treatment for this. This was another patient, only eye patient in a right eye, and you see the closeness of the fronts to the fovea. Fovea itself is enlarged. They're big fronts, very close to the fovea. This patient not been lasered, first time visit. Again gave ranibizumab. This repeated this effect just to show that this front has gone, absolutely gone. And then I lasered this patient. So I'll in brief tell about this IDDM because IDDM worries me more than NIDDM because there's a rapid progress in such with this lady, young lady, IDDM, working in a Google, company, irregular follow-up because the vision was good because everybody showed follow-up, after 1 year, but this lady lost vision, and even at 6/9, she had such rapid, proliferation if you compare from 2018. And once she developed a TRD involving macula and nasal, then we operated during this COVID times only. This was the story of the other eye, equally bad, but we operated this eye first. Fortunately for me, she has 6/12 vision in each of the eye after surgery. But moral of the story is, I want to intervene much earlier compared to, you see, this is a story of another PDR patient who was intervened much earlier. And you see both eyes enjoy 6/6 vision. So I'll just, play a very short video and run through it. This is the video of that young lady IDDM who had florid PDR. And what Saurav was telling, bimanual surgery still has a role, even though the port size has become smaller or 10,000 cut rate has come. You see, this kind of surgery cannot be done without a bimanual approach. So I initiated this surgery, trying to pull at the optic nerve just to initiate a small separation plane there. And once this separation plane was there, and you see all the retina is bulging into that, and then we had this cutter, did a lot of segmentation here because there's so much florid neovascularization and traction involving virtually all the quadrants, and very slowly, try to trim these areas. We'll just run through it. These are difficult vitrectomies. They may take more than 1.5 2 hours. Then injected some PFCL to stabilize after I segmented this from the posterior pole. Still, there were a lot of fronts left, and this is the time when I started this bimanual surgery in this patient. inserting what Saurav also said, the chandelier system, which has a role to play in this difficult diabetic vitrectomy, especially with the forceps in one hand and scissors in the other. Curved scissors is one thing which I will never start any diabetic vitrectomy without reassuring that curved scissors is available, because the precision with which this scissor adds to the cutting of these membranes atraumatically without causing a break, which cannot happen with cutters. And once this has been done, then you trim this, take care of other membranes here, do diathermy because that is very, very significant. I don't depend on laser for stopping the bleeding. Diathermy is a must. Diathermy is another very important instrument before we start a diabetic vitrectomy. And then ultimately you do a fluid exchange, laser all the iatrogenic breaks which you may have created. And fortunately, this patient, and PRP has to be added totally. So we'll skip the other video. So vitreous surgery for me, threshold has gone down and sort of very nicely demonstrated a lot of applications of MIVS. We no longer wait, for weeks or months. Within 2 weeks, if the patient not doing well, we try to intervene. And non-swollen vitreous hemorrhage, at least in our practice, has become a very rare entity. Most of the patients are diabetic will present as macular TRD or a combined RD. So there's some of the pre-op and post-op patients of bad TRDs managed with the MIVS, which sort of described very very nicely. The other patient fortunate to have 6 by 6 in both the eyes. This was another story of one-eyed patient. So outcomes are really improved with the kind of equipment which sort of showed very nicely with wide-angle viewing. Ultimately, believe me, all VR surgery is visibility. If you can see, anybody can do a good job. So PDR management in brief, I still believe laser is the mainstay, and good scatter laser, if you have done a good scatter laser without skip areas, has saved many eyes for many, many decades. Anti-VEGFs, I still feel have an adjunct role only, whatever AB study may say, because there's an issue of repeated injections, there's an issue of cost, there's an issue of multiple visits, and our population may not come back for all these things. Indications to me could be a recurrent small ooze despite laser with good vision, or posterior pole large front which I showed with good vision. These are the situations where I would consider anti-VEGF injections as a primary, but add on with laser also. And I still believe early MIVS, early PPV is relevant for long-term stability of these patients, because we should not and we cannot wait too long. Otherwise, believe me, these diabetic TRDs go very, very bad. And your aggression during surgery should be very calculated, because ultimately you want to help the patient, you want to give back some vision to the patient. Prognosis, as I said, is definitely improved.
Thank you so much, sir. Your pearls really help us in PDR. Your experience is more important. Of course, these studies are ongoing, but you have seen in first-hand experience, how to treat these patients, and you know what works, especially in an Indian scenario. Thank you so much.